Hello and welcome. In chapter 5, we're talking about depressive disorders. These disorders feature sadness, emptiness, irritable mood, accompanied by somatic or cognitive changes. The disorders in this section are disruptive mood dysregulation disorder, DMDD, major depressive disorder, persistent depressive disorder, premenstrual dysphoria disorder, substance or medications induced depressive disorder, depressive disorder due to another medical condition, other specified depressive disorders, or unspecified depressive disorders. So let's talk about DMDD. The onset must occur before age 10 and not diagnosed before age 6 or after age 18. So this is going to be largely for adolescents and youth. So they're talking about temper outbursts, where we're talking about rage, physical aggression towards people or property that are out of proportion of the situation. The frequency is an average of 3 or more times per week. Mood fluctuations. Between these outbursts, parents see their children most of the day as irritable or angry. Duration, the child has not been without a relief period for symptoms longer than 3 months. The setting, the child has trouble functioning in more than one place, home, school, social settings. Exclusion, the behavior does not occur exclusively during an episode of a major depressive disorder or is not explained by another disorder. MDD, major depressive disorder, which is probably the major disorder in this section. These are individuals that possess pessimistic mindsets, little or no sense of hope for themselves or their future, and they also have some somatic complaints. The language of the clients may reflect expressions of depression such as worthlessness, loss of energy, and marked loss of ability to experience pleasure. Physical changes, referred to as vegetative states, are critical determination of disorder. So clients with, again, limited motion don't get out of bed. They most appear to be in a vegetative state. The symptom picture for major depressive disorder, there must be 5 or more of the following: despondent mood most of the day, nearly every day, marked or diminished interest, significant changes in weight, vegetative features, psychomotor agitation, fatigue or loss of energy, feeling worthless or experiencing excessive guilt, inability to concentrate or think, and recurrent thoughts of death or suicidal ideation. So the specifiers, again, things that bring out that clinical picture more. You can specify if the client is with anxious distress or with missed features or melancholic features, atypical features, psychotic features, catatonia with seasonal patterns or severity and remission of the disorders. And again, the ICD-10 code can change based off of certain specifiers or if it's a recurrent episode or first episode, right? Those things can change the ICD-10 code, so you have to pay close attention to that. So persistent depressive disorder, dysthymia, again, largely found in kids or whatnot. This is when you have this is a lower level from major depressive disorder. It's not as severe, right? But you have chronic depression that lasts often for years. Clients see this mood as normal. A chronic mood depression that lasts at least 2 years or more. So again, you got to find that 2 year window. Evident more days than not. It's not severe enough to fit the picture of someone with major depressive episode. And a person that exhibits at least 2 or more of the following: increased or decreased appetite, or increased and decreased sleep, low energy, self-esteem, poor concentration, or hopelessness. So suicide is a complication for mood disorders. So we want to look at these warning signs. If there are changes in appetite, speaking or moving with unusual speeds, unusual neglect of one's physical appearance, difficulty concentrating, giving away prized or valued possessions, saying goodbye to family or friends, involvement in destructive or abusive relationships. Younger children or adolescents may be bullied or bully others because of their suicidal ideation. So there's 4 basic types of medication for these: SSRIs, mixed reuptake inhibitors, MAO inhibitors, right, and tricyclic antidepressants. All these are different antidepressant medications that can treat and actually um, engage with some of the neurotransmitters that go along that go along with any depressive disorders. So you want to watch for these things. Again, we're not able to diagnose or we're not able to prescribe, but it's really important that we understand the differences in these medications or whatnot, so we can better treat. So alternative treatments to antidepressant medications. So St. John's Wort, this is the hypercurrent is a natural herbal extract currently available in health food stores, drug stores, and similar outlets. Electroconvulsive therapy. Considered one of those instances where a person does not respond to medication, which consists of electric shot, is administered directly through the brain for a very brief period of time. So the minor depressive disorders are premenstrual dysphoric disorders associated primarily with the later phase of the menstrual cycle, consisting of clusters of affective, behavioral, and somatic symptoms. Substance and medication-induced depressive disorders reserved for depression that is induced by alcohol or drugs. Depressive disorders due to another medical condition. These are medical conditions that can lead to a state of depression. And others specified or unspecified. These are reserved for when the person shows characteristics of depressive disorder but do not meet full criteria for any of the specific diagnostic classes. And again, DSM-4, there was big changes from the DSM-5 and DSM-4. A new disorder was created. The disruptive mood dysregulation disorder was introduced for children. The bereavement exclusion was removed. Specifiers were added to depressive disorders, like with mixed features or with anxious distress were added. The term dysthymia is now termed persistent depressive disorder. And premenstrual dysphoric disorders was removed from the DSM-4 appendix for further study and introduced as a disorder in DSM-5.